Doctors put in grueling hours, routinely face life and death situations, and endure intense physical and emotional demands, never more so than during a global pandemic. What is less well known is how they handle it all. Dr. Jillian Horton is an internist and medical educator and now author of We Are All Perfectly Fine, a memoir of love, medicine, and healing. And it brings her to our virtual studio tonight from Winnipeg, Manitoba. It is great to meet you. I absolutely love the book. How you doing, Doc?
I'm doing okay. Thanks so much. It's great to be here with you.
Not at all. Now, I must tell you off the top, I've talked to lots of doctors over the years, and almost all of them get into medicine for a very particular and often a very personal reason. And I know, having read the book, that is the case with you. Why don't we start there and you tell us how and why you got in?
So I grew up with a sister who was profoundly disabled. She had a pediatric brain tumor, and from the time I have really my earliest memories, I had a ton of exposure to seeing how the medical system treated her. And while there were some really compassionate and wonderful doctors in the midst of her care, there were also a lot of encounters with the medical system that were awful, that were devoid of compassion. I saw the stress that it created for my parents, the moral distress. I saw the humiliation involved on the side of our family in those encounters when we sort of were depersonalized or felt dehumanized. And it really gave me an inside knowledge that I hit a point in my life that I just thought, I can't have this understanding of what's wrong and not somehow use my abilities to try to fix it so that other families don't go through the same thing.
When the encounters were bad with people within the healthcare system, what did you attribute their inability to be human with you to?
Well, when I was younger, I really saw this as just cruelty. You know, I saw it as ableism. I saw it, although we didn't even have that word in our vocabulary at the time, but it was certainly clear to me that people attributed a lot of the issues that my parents would continue to bring to physicians and to other members of the healthcare team, that people just attributed that to, like, my parents being troublemakers or my sister being a really difficult case or a difficult person. She really had an acquired brain injury after her brain tumor. She had a postoperative meningitis, so she had a lot of behavioral issues, and people just sort of blame my parents for that. A lot of different specialists would frame it as if, my parents had just never taught her manners or didn't teach her any way to control her behavior. So looking back, certainly some of the problem was ignorance and just a lack of understanding of the complexity of head injuries. It wasn't until much later in my own career in medicine that I began to understand that at least some of those behaviors, and I would never make an excuse for them, and I don't think it is an explanation for all those behaviors, but I think some of them at least could be explained by physician burnout.
Okay, we're going to get to that more, but I do remember reading in the book probably the worst thing one doctor said to either you or your folks about the status of your sister's brain. You want to share that story?
Yeah, so this is part of my family's lore. This is something that happened before I was born. So my sister, after her brain tumor was removed, she actually had a very kind and compassionate surgeon and pediatric neurologist in London, Ontario, and then came back to Manitoba. And at one point during her very long, prolonged convalescence in the hospital, a physician took my parents over and showed her some scans and basically yelled at my parents, "Can't you people get it through your head? This child has no brain left." And that story, perhaps more than any other that my parents told me about their encounters with the medical system, was one that resonated more than anything. I think even all through my training, I thought no family member should ever be subjected, no patient should ever be subjected to that kind of cruelty, that kind of language, that kind of experience from the medical system. It's traumatizing, and it leaves lifelong scars in patients and families when they're treated that way.
So that was pretty clearly very motivational for you to try to get in there and do it differently, yes?
Absolutely, absolutely. And I always thought of myself when I first went into medicine as a bit of an outsider. And I'm not saying I was, once I began my studies and carried on in my residency, I have had hundreds of colleagues, thousands of colleagues probably, if I really started to look at every wonderful person I've worked with in allied health and nursing and members of the healthcare team, nurses, aides, physician colleagues who represent the best of medicine, the best of compassion and the way that we would all want to be treated. So I found those people too. But of course, alongside of them, I also saw this other ugly side of medicine, the way that people would sometimes speak about patients, the way that, just like my family, having been described as having been perceived and treated as if we were, my parents in particular, advocating for my sister as if they were difficult or demanding. I saw a lot of that side of things too. And there was a big part of me that was continually motivated by that, but that also this was a wound that went on and on. Every time I saw a patient that reminded me in some way of that experience of powerlessness that my parents had had, that I had experienced as my sister's advocate at different points, as her sibling. Every time I had those experiences, they would continue to probe that wound and make me reflect and just think, why does our system have to be that way? How has it come to this?
We are, I promise, going to talk about the issue of physician burnout, which is, after all, what the book is about. But I still want to tell a bit more of the story, or have you tell it, on how you got there. And one of the things I'd like us to touch on now, some doctors form very deep bonds with some patients. And some of your stories in this book are just incredibly touching in the way that you did that. And I wonder if you could share with us the story of Michael, which was, oh my God, this is just, anyway, the floor is yours.
Yeah. So you touch on something so important, Steve, before I talk about Mike. And it's the idea that there are many patients in our careers, especially early in our careers, patients that we carry with us our entire lives. And one of the amazing things for me, one of the incredibly cathartic things, not only about going through the experience at Chapin Mill, but about writing this book, is I actually, of course, in order to write about any patient and share a true story that requires consent and participation of either the patient or, in this case, their surviving family members. So one of the things that I sought to do with this book was write about a couple of patients that I'd cared for 20 years ago, and I had to track down their families. And for me, this was just really a profound experience. This is a real gift that they gave me to allow me to write using their real names and their real stories. So that has been an amazing part of this book for me. But the story that you allude to, and one of the central stories in the book, is that of a patient by the name of Michael. And Mike was a patient with cystic fibrosis. I met him when I was an intern, still very much during my formative years working at St. Michael's Hospital on a respirology rotation. And Mike was around the same age as I was and had a lot of the same interests. He wanted to be a filmmaker. He was really interested in the cinema. And sometimes, even when I wasn't on respirology and went on to other services, because Mike was in the hospital so much, he would be in the coffee shop playing cards or reading. And we just, after I had been on the rotation that he was a patient on, we knew who the other person was. And then sometimes late at night on call, I'd be there and I'd sit down and start talking to him. And then when I went on to another hospital for my next clinical rotation, he was a patient at that hospital a few months later getting a transplant. And so not only did he keep popping up in my clinical life, but we connected on a personal level. And Mike would send me postcards and letters. We would email, we would talk, and I got to see him have a lung transplant and have a significant profound return to, come back from this severe illness, this sort of one foot in the grave situation that he was in, and come back to looking like a healthy person, just the way I did. But then after several months of his return to normal life, Mike became ill again, and I was not able to connect with him before he died, which was when I learned that afterwards and happened to learn of his death in passing was a hugely devastating experience for me, and something that I really carried as a profound weight for years and years after that. And at Chapin Mill was actually one of the first places where I ever really discussed the loss that I felt with Mike and the profound grief that I felt after he died. And actually one of the really lovely things when I tracked his surviving brother down and connected with him was his brother he found a few notes that I'd written to Mike in his things, and he actually sent those to me and mailed them to me. And it just, I think, is such a testament to the fact that we care for these people, but they come with us. And if we never do anything in the future to tend to those unresolved losses, we never talk about them, we never think of them as ours, we're sort of disenfranchised, you can begin to understand the chronic cumulative grief that doesn't go anywhere, that isn't really managed. It's not really physician culture to manage it. So that is a big part of what I went through in this book, and what I've learned to do since my first trip to Chapin Mill is work differently with a lot of these unresolved tragedies, just learn to respond to them, to see them differently and process them differently in my life.
Well, you've mentioned it a couple of times, so let's go there now. Chapin Mill is this place. It's actually not that far from here. It's in upstate New York, I guess between Buffalo and Rochester. And it's the place where you found yourself, along with many, many other doctors, who felt burned out and needed to heal. What was it that finally got you to admit that I am in a disastrous place and I need help?
Yeah, it was kind of a chance encounter, actually, and for a few years before I first went to Chapin Mill, I had been a student affairs dean at my medical school, looking after hundreds of medical students and feeling vicariously their emotional challenges and their distress as they tried to navigate medicine. And I really began to look at what's out there, like what is actually going to help that I can teach to these students, because I sometimes felt that even though I had an almost bottomless well of compassion to share with them and to model for them, I also didn't exactly know how to deal with some of my own building distress and some of my own sense that medicine was beginning to take a greater toll on me than I could really bear. And so as this was all building in my life, a physician who is one of the founders of that program in Rochester happened to be giving rounds here in Manitoba and was doing a workshop, and a friend urged me to go, a friend who practices mindfulness, who works in healthcare herself. And I went, and I really liked this guy. I thought he was funny, he was cool. I sort of expected him to be a bit flaky and granola, and he wasn't that way at all. And he said to me, "You should come to Chapin Mill. I hope you'll come." And I, on a whim, thought, I might as well go. It looks like a nice place. And I made the arrangements, surprising a lot of people in my life that I would go to something like this. And I went with, I think, a bit of cynicism in my mind and my heart, not really expecting it to be a profound experience, expecting it to be something that I would come home and chuckle with some of my more cynical friends. And in fact, I came back from that first trip with an intent and maybe with, for the first time, some skills to make a profound change in my life in terms of how I dealt with the ways that medicine affects us.
Well, before you got there, you were a bit of a tough customer, I have to say, because they told you to leave your phone in your room and you wouldn't do it. You kept it with you and you kept sneaking looks at it from time to time. But what essentially did they have you doing over the 5 days that you were there?
So we do three main things in this program. And I've been back more than once. And actually, I've done some training, quite extensive training actually now to teach that program. And I teach it to physicians both locally and nationally and all over North America now, which I also would never have imagined would be something that would happen. But we do three main things. And one is we do meditation together. We do formal and informal meditation, some of it sitting on the cushion, some of it other kinds of meditations, walking meditations, things where you focus on particular things in your environment. We do a lot of paired structured storytelling. So sitting down with a partner in a confined period of time, just the way I describe in the book, and sharing a story in a particular way using particular tools. And one of those tools is looking at stories from a strength-based approach. So instead of what we typically do in medicine, because we're all heavily type A and extremely driven, we tend to look at stories in our lives through the lens of failure. When I look at stories of things that have gone wrong with patients, I look at mistakes that I've made and things I wish I'd done differently. And there's a big reframe that happens at Chapin Mill, which includes looking back at some of our losses, some of our traumas, some of the cases where we really wish things had gone differently, and instead focusing on learning, focusing on what we actually did well in those moments, and looking at how those stories fit into the bigger pictures of our personal development in our lives. And this might seem basic, but this is not something that comes naturally to most physicians.
I did wonder, given the type of personality that tends to go into medicine, as you've just described it, how long does it take before you stop saying to yourself in this idyllic surroundings, boy, this is a lot of airy-fairy crapola, and I just can't buy into any of this? How long does it take to lose that attitude?
Well, for me, the first time I went down, I would say it took about 3 days. So for the first couple of days, like you said, I was looking at my phone and I was still thinking a lot of these people are really weird and what's their deal? And, something interesting happened. Like by the third day of doing those practices and doing some of the meditation experiences, I noticed I started to feel better. And I don't mean I felt suddenly magically relieved of everything that was distressing. I just noticed little bursts of peacefulness, of calm. And it suddenly made me aware of how rarely I felt that kind of peace and calm and sense of well-being in my life. How the word addicted is maybe not quite the right word, but how just accustomed I was to feeling awful, to living with chronic stress, to always worrying about what was happening at the hospital, to perseverating about the students that I was tasked with looking after, to worrying about whether there was something on a clinical service that I'd just been on that I might have missed or that I could have done better. And this was the first time that I really had begun to believe in these small glimpses that maybe there's a different way to exist. Maybe this is habitual. Maybe my brain, having been wired this way over all these years of working in a chronically overstressed environment, maybe I have a choice in that. And again, when I say that now, it doesn't seem like that big of an idea. But at the time, for me, this was a profound reframe. And actually, I think it's a profound reframe for a lot of physicians. I think a lot of us have become so used to living this way that when someone suggests maybe there are a few things that we could do to make ourselves feel better, that are meaningful, that are impactful, even that idea is overwhelming. And it's also really threatening in a sense, because so much of what causes our distress, like if we look at physician burnout, we know that 80% of the problem is related to the system factors, medical culture, organizational factors. It's not a problem of me not being resilient enough. This is another falsehood that sometimes has permeated medicine, that when we struggle, that it's because we're too weak, that we can't handle the pressure. And when we look at studies on physician resilience, physicians are actually more resilient than their age-matched controls. And there's been a lot of excellent data showing this. So when you say to yourself then, well, the problem isn't that I'm not resilient enough and I'm really suffering, so the system needs to get fixed. System change happens really, really, really slowly. We can make personal change a little bit more quickly, and then personal change allows us to be more effective as leaders, making that system change. So those are all thoughts and concepts that gelled for me in a really important way during my first pilgrimage and subsequent trips to Chapin Mill.
Well, here's an excerpt from the book that I think amplifies on that message that you just gave us. So, Sheldon, if you would, let's bring this up. And here's an excerpt from the book. Burnout isn't a clinical diagnosis, right? It's a phenomenon. But you take a bunch of people who are altruists and perfectionists and have the same baseline predisposition to mental illness as the rest of the population, and you put them in, quote unquote, jail for 5 years, and you script everything they do, right? You limit their sleep, you limit their food intake, you cut them off from their loved ones, they kill a few people by accident, and you tell them everything is their fault. But if they keep their mouths shut, maybe nobody has to know what they did. But in return, they have to take over running the prison, do it to the next generation. That's a pretty awful indictment on the system in which you make your living. Why would anybody want to become a doctor knowing that's waiting for them?
That's a great question. One thing I would say is I don't think most of us do know that that's what's waiting for us. We don't really understand this culture until we're deeply immersed in it. And then the problem, of course, becomes we don't see the culture because we're deeply immersed in it. We no longer understand it. We're the fish who can't really describe water because it's everywhere around us. So that's the first thing. I think a lot of us don't really understand the kind of emotional deformity that may occur to us during the course of our training. And so we plunge right in. And there's another thing that happens, and this passage that you've chosen sort of touches on it. And it's the idea of a cycle of retribution instead of restoration. And this is a big pain point, I think, for a lot of physicians in older generations. You know, we're looking now at doing things like, and in some places we have done things like limiting call shifts, limiting a call shift to no more than 24 hours of being awake. And in some places, sometimes our residents will be capped at 16 hours, which is still a pretty long shift when you think of the kinds of things that they're doing. But there can be a lot of tension because sometimes older physicians, and I'm decidedly mid-career now myself, can look at this and say, well, I had to do this. I had to stay up for 28 hours. I had to do 1 in 4 call in the hospital. Nobody limited my patient load. Why should these other people have it better? This is a knee-jerk reaction that comes out of, again, it comes from a place of pain. It comes from an unmet need. And I think sometimes when I try to analyze the roots of it, I think when we go through any really horrible experience in our lives, sometimes to try to create a narrative that allows us to conceive of ourselves as having been in control, we say, well, I learned a lot from that. That adversity made me a better person. Now, our adversity in our lives, I mean, most of us, the really difficult things that we've been through, we can also trace some of our best qualities to those experiences. So it is true that difficult things that we go through can lead to profoundly wonderful characteristics in us. But the flip side is there does come a point when that can no longer be true. And so I think a lot of the time physicians are saying, well, this made me who I am, and they're just blind to it. And I would also say, you know, my residency, the entirety of it was not horrible. I had many wonderful experiences. I had some incredibly compassionate, amazing, profoundly wonderful mentors, and some amazing times and some deep relationships that formed with colleagues who are still among my best friends during those years. So people, I don't want to frame it as if it was all awful, but it was brutally hard. And I don't think it has to be that hard. I think a lot of what we have made difficult about medical training, the profound sleeplessness, the emotional repression, the kind of volume, the caseload that we sometimes are expected to carry, we can change those things. It just becomes a question of, is our culture ready to acknowledge that things about it don't have to be the way that they have been, that it's a fallacy, that it has to be that way.
Dr. Horton, COVID-19 has obviously made things a lot worse for people who work in healthcare, doctors in particular. The stress must be unbelievable. I talk to doctor friends of mine who say they are just inundated all the time. Do you think the problems that sent you to this retreat in the first place are, I mean, how much worse would you say they are right now in a pandemic?
I think that's what is such a crisis for us in terms of COVID. It's that we were not in good shape going into this. We should have been ideally in, the way that you would feel at mile 1 of the marathon. And instead, our general shape was a lot more like mile 24. So I think that is a significant part of what is happening to physicians and all healthcare providers right now. By the way, I talk about physicians because that's the data and literature that I know, and certainly nurses and all allied healthcare providers are really struggling. But we know that doctors going into this were in a burnout crisis. It's been called a public health crisis by many large bodies in North America. The data tells us that. And I think this is going to be one of our tipping points. I think we're going to see, as I've written elsewhere, a wave of early retirements. I'm worried that we're going to continue to see, we've already seen physician and nurse suicides tragically, horrifically in Canada since the pandemic started. Physicians already have one of the highest rate, the literature seems to say, among white collar professions for completed suicide. So that's my biggest fear. And it was my fear just a few months into the pandemic that this was going to be a perfect storm for us for either tipping people into disaster, or a more hopeful interpretation is to force our hand as a profession to really begin to look at some of the problems that we have dealing with stigma and mental illness, issues with physicians not wanting to disclose mental health diagnoses because of licensing issues, very real concerns there. And it's quite possible that the stress and distress associated with the pandemic is going to be a cause of positive transformative change ultimately in terms of how physicians see seeking resources, in terms of what organizations see as their obligation to provide resources, to provide support, and how we handle our own stress and distress going forward.
Dr. Horton, the time has flown by, and I have one more question left, and I want to pluck it right out of the book because I take it from a conversation you had with a guy you're calling Roy. And you really do ask two fabulous questions here. Do you think the problem is we're holding ourselves responsible for things that aren't our fault? Or is the problem that we need to forgive ourselves for the things that actually are our fault? Did you ever get to a satisfactory answer to those questions?
Well, I think most emotionally intelligent physicians that I know who are still carrying the kinds of patient stories and experiences that you allude to, Steve, and the ones that I shared in the book, I think we do all still have work to do on forgiveness. I think most of us still have taken responsibility for things that aren't actually our fault necessarily in our personal histories. And I think that we are also working in an impossible system. And I hope that one of the restorative things that we all, everyone in medicine, everyone in a position of leadership in medicine in the coming years, I hope we take it upon ourselves to try to create a system that is different for the future generation, that we see that not as something that we're giving up, that someone doesn't have to go through what we went through, but that we can reframe that and see that as a gift, not only to those learners, our students and our residents, but also that we can see that as a gift to patients. Because if the system can become more compassionate, it will allow physicians and all healthcare providers to have more compassion for themselves, and then everybody will win.
They could start with reading this book. I think this ought to be required reading for anybody who wants to go into healthcare. We Are All Perfectly Fine, a memoir of love, medicine, and healing. Dr. J, that was really outstanding. Thanks so much for joining us on TVO tonight.
Thank you so much, Steve. It's absolutely my pleasure. Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.